Okay, so thank you everyone for joining us for my dissertation defense and for my family and friends for being here for such an important event in my life. I'm excited to discuss some of the studies that I've been working on for the past 5 years, where I focus on utilizing the cognitive phenotyping approach to studying the neuropsychological syndrome of temporal lobe epilepsy, or TLE. So the overall aim of the dissertation was to identify cognitive phenotypes in temporal lobe epilepsy, examine the neurocorrelates associated with these phenotypes, investigate the methods for defining phenotypes, and examining both the epilepsy and health-related and protective factors associated with cognition. So in the first study, we focus on examining the underlying white matter associated with each phenotype. In the second study, we conduct a head-to-head comparison between two phenotyping methods. And then the third study was focusing on examining an advanced method to clustering. And lastly, I provide some preliminary findings that will be included in a future study where I examine contributions of non-epilepsy factors to cognition. So some background about epilepsy and TLE specifically. Epilepsy affects approximately 50 million people worldwide, and TLE is the most common form of localization-related epilepsy. Individuals with TLE experience focal seizures with and without secondary generalization, and is characterized by seizures originating from the temporal lobes, including mesial and lateral temporal structures, with the most common pathology being mesiotemporal sclerosis, or MTS, which is atrophy and gliosis of the hippocampus. And then lastly, TLE is the most refractory to anti-seizure medication, which means that a large proportion of patients would experience recurrent seizures, making TLE a chronic neurological condition. And given the impact of seizures, medications, and other treatment, epilepsy is associated with significant cognitive and neurobehavioral comorbidities. And for over a century, the lesion model has been the predominant method to studying the cognitive and behavioral complications of epilepsy. So this model assumes that cognitive and behavior changes are circumscribed to the seizure focus, which have yield syndrome-specific cognitive profiles. So for example, patients with TLE were thought to have impairments in memory, and those with frontal lobe epilepsy, or FLE, were thought to have impairments in executive functioning. However, the cognitive deficits observed across different epilepsy disorders are more widespread and generalized than hypothesized by the lesion model. So for example, patients with TLE also demonstrate impairments in language, and those patients with FLE demonstrate impairments in language, all cognitive domains associated with extratemporal and extrafrontal regions, respectively. We also observe language impairments in patients with seizure originating from a non-dominant hemisphere, and their overlapping deficits across different epilepsy syndromes. So the widespread cognitive deficits may be in part explained by a plethora of neuroimaging findings demonstrating widespread brain abnormalities across different epilepsy syndromes. In TLE specifically, there are widespread structural and functional abnormalities extending the temporal lobes, including cortical thinning, diffuse white anomalies, and the presence of pathology that's extratemporal in nature. Then given these findings, TLE and other focal epilepsy syndromes are now considered network disorders. And some of the most compelling evidence are reflected in several publications from the Enhancing Neuroimaging Genetics through Meta-Analysis, or Enigma Epilepsy. Work led by Whelan et al. Demonstrated that despite syndrome-specific findings, all patient groups demonstrated reduced thalamic, hippocampal, and right palatal volumes, as well as bilateral increases in the volume of the lateral ventricles. Furthermore, widespread cortical thinning that was shared across epilepsy syndrome was also observed. And then in a subsequent study looking into the integrity of the white matter, Hatton et al. Demonstrated that there were similar bilateral alterations in many anterior midline fibers across patient groups. These studies and several others from Enigma Epilepsy could explain the distributed nature of cognitive impairment observed within and across epilepsy syndromes. And to better understand the cognitive heterogeneity, there was a shift from examining TLE patients in aggregate to identifying latent profiles or cognitive phenotypes within TLE. And this work was pioneered by Dr. Bruce Herman. In his first study, he identified 3 major groups, which included patients that demonstrated impairments across all measures, a second group of patients with predominant impairments in memory, and then a last group of patients that show minimal impairment. In a follow-up study, the same groups demonstrate a unique pattern of cortical atrophy with patients with worse cognition showing widespread cortical thinning and patients with minimal impairment showing the least atrophy. So this new approach has important implications for neuroimaging and neuropsychological studies in epilepsy. So in the traditional lesion model, patients are first grouped by epilepsy disorder. So for example, all patients with temporal lobe epilepsy. And then second, the relationship between the epilepsy pathology and cognition is studied at the group level. And then lastly, we attempt to make inferences about the impact of epilepsy and cognition based on these group findings and apply this knowledge to individual patients. However, in the spirit of precision medicine, the phenotype model takes a more individualized approach. So patients with the same epilepsy syndrome are grouped into phenotypes based on their pattern of cognitive impairment, and then the relationship between epilepsy pathology and cognition is studied at the phenotype level. And then lastly, inferences from these findings are then applied to patients that demonstrate very similar cognitive profiles to the phenotypes. So as previously mentioned, the aim of the dissertation was to use this approach to better understand why some patients with temporal lobe epilepsy demonstrate generalized cognitive impairment, while other patients have minimal impaired cognition despite having similar clinical profiles. Specifically, we hypothesized that patients with generalized impairment will also present with other comorbidities and a greater brain abnormalities, and that those with minimal impairments will demonstrate protective factors. Importantly, as demonstrated in the previous studies, the phenotype approach can better delineate the underlying brain changes associated with the extent of cognitive impairment that is otherwise obscure when aggregating all patients into the same epilepsy group. Thus, this approach provides an innovative method to arriving at patient-centered cognitive risk. So the first study was published in Neurology, and we used this approach to identify distinct cognitive phenotypes in CLE and evaluate the patterns of white matter network alterations associated with each phenotype. So first, we hypothesized that distinct cognitive phenotypes can be identified using language and memory measures. And then second, we hypothesized that each phenotype will demonstrate unique patterns of network disruptions. Specifically, patients with language or memory impairment only will show significant mesial versus lateral temporal pathology, respectively. And then those patients with impairments in both domains will demonstrate widespread frontal temporal pathology. And then lastly, we anticipated that patients with minimal impairments will show minimal changes in white matter structures. So we had 3 measures of memory and then 3 measures of language. And then we divided 70 patients based on neuropsychological criteria. This was a modified criteria based on the aging literature, where a patient is impaired in a domain if 2 or more of the 3 cognitive tests fell within the impairment range of 1.5 standard deviation below the healthy controls. This clinical approach dealt 4 groups. We had a group of patients that were impaired in language and memory, a second group of patients impaired in memory only, a third in language only, and then you had the 4th group that show minimal impairment. And then when examining the clinical and demographic profiles across the phenotypes, we found that there were only differences in age of seizure onset, with the memory impaired group demonstrating an older age of seizure onset relative to the other groups. And then we examined the underlying white matter. So we did this by looking into traditional white matter tracks, most frequently implicated in verbal memory and language processing, that are also reported to be compromised in temporal lobe epilepsy. We also looked into the superficial white matter, which are the U-shaped fiber right underneath the cortex that has been hypothesized to be important for cortical connection. We calculated a fraction esotropy and mean diffusivity, and in the context of epilepsy, decreases in FA are thought to represent axonal loss, and increases in MD are thought to represent demyelination. So we first compared these diffusion metrics within the superficial white matter between cognitive phenotypes and healthy controls. And then in patients with both language and memory impairments, we found widespread reductions in FA and left lateralized increases in MD. And then in those patients with memory impairments only, we've observed higher MD in the inferior and medial temporal lobe regions bilaterally that included regions important for memory. And then we found when looking into those patients that were language impaired only, we didn't find any differences relative to healthy controls. And this pattern was also observed in patients with no impairment. However, patients with language and memory impairments demonstrated left lateralized increases in MD relative to the non-impaired group, highlighting some within TLE group differences. So then regarding the white matter tracks, we found that patients with both language and memory impairments had decreases in FA and increases in MD in several tracks, where patients with isolated memory or language impairment had also isolated white matter tract disruptions. And then lastly, those patients with no impairment did not demonstrate any differences. And then when examining measures of network integrity, patients with language and memory impairments show differences across several network-based metrics, including decreases in global efficiency, increases in transitivity, and decreases in modularity, all suggesting a more lattice-like network configuration, which it is thought to reduce the efficacy of information transfer. On the other hand, patients with isolated language impairment show intact global network structure with decreased local efficiency within the left and right superior temporal gyrus, or SCG, suggesting less integration of the SCG with other language regions. Now, these findings demonstrate that there's a differential pattern of white matter microstructure abnormalities across these distinct cognitive phenotypes in TLE that can be appreciated both at the regional and network levels. So in summary, study 1 demonstrated that patients in the language and memory impaired groups demonstrated pronounced microstructural changes within superficial white matter regions and deep white matter association tracts implicated in language and memory. We also show that patients that demonstrate impairments in both domains had the most pronounced alterations in regional and global network structure. And then patients in the language impaired group show abnormal network structure within the superior temporal gyrus that's critical for language, despite having relatively intact global network structures. Then lastly, those patients with no impairment show relatively normal white matter structures. So study 1 has several limitations that were addressed in study 2. First, we use the clinical criteria to derive the phenotypes. However, the most common method in the phenotype literature has been data-driven approaches such as cluster analysis, and therefore arriving at consensus on the appropriate methods of phenotyping or whether different methods are concordant is critical. Second, we only included measures of language and memory, and while impairment on these domains are the most pervasive and problematic morbidities, patients also demonstrate impairments in executive functioning and processing speed. And then lastly, we only use single site data, and therefore examining these phenotypes in large multi-center samples will be important for the generalizability of the phenotypes. So in study 2, we did a head-to-head comparison between the two methods of phenotyping. The clinical criteria is similar to the one used in study 1, and cluster analysis, which, as I mentioned, is one of the most commonly used data-driven methods in the phenotype literature. So the aim of this study, which was published in Epilepsia, was twofold. First, we were interested in replicating previous findings using both approaches and examining the clinical profiles associated with each phenotype. And then second, we were interested in comparing the concordance rate between both approaches with the question of whether data-driven methods classify impairments to a similar degree as the clinical approach. So we had 407 patients with temporal lobe epilepsy, representing the largest phenotype sample when the study was published. We expanded our neuropsychological measures from study 1 by also including measures of processing speed, executive function, and motor dexterity. So for the clustering approach, we subject patients' Z-scores on the neuropsychological measures to K-means and use an NB+R package, which provides several indices of fit to determine the optimal number of clusters. Then lastly, we examine the Dunn index, which is a metric of clustering algorithm with higher numbers indicating compact, well-separated cluster. And then for the clinical criteria, impairment was set to 1.5 standard deviation below the mean of healthy controls. And then patients were divided into 3 groups based on prior literature, which included a group of patients with generalized impairments defined as having impairment in 4 out of the 7 tests with at least 1 per domain. And then we had a domain-specific group, which was defined as having 3 out of the 4 tests in memory and language impaired. And lastly, the normal profile group, which was defined as having 1 or none of the tests impaired. So for cluster analysis, a 3-cluster solution was selected, which consisted of cluster 1, comprising 29% of the patients, which impaired across all tests, as we see in the navy blue. And then cluster 2 was 28% of the patients, which demonstrated impairments predominantly in language and memory. And then cluster 3, which was 43% of the patients, which showed minimal impairments. Now, for the clinical criteria, the sample was almost equally divided into 3 groups, which were selected a priori. So we have a group of patients with generalized impairments, a domain-specific group with 30% of the patient, and then a non-impaired group, which was about 33% of the patients. So regarding the clinical demographic profiles across the clusters, we found differences in education, age of onset, and the presence of mesiotemporal sclerosis, or MTS. We found that patients in cluster 2, which was those patients with language and memory impairment, had less years of education relative to the other 2 groups. And then cluster 1, which was the generalized impaired group, had a younger age of onset relative to the other 2 groups. And then lastly, the patients in cluster 3, which is a minimally impaired group, had less patients with MTS. And then a similar pattern emerged looking into the clinical phenotypes, so the patients that were classified using the clinical criteria. Again, we see differences in education and age of onset. And although not significant, there was still the trend for MTS. So again, the language and memory impaired group had less years of education relative to the other 2 groups. And those with generalized impairment had a younger age of seizure onset relative to the other 2 groups. And as I mentioned, there was a trend for the non-impaired group to have less patients with MTS. And then lastly, there was a trend towards the generalized impaired group as having a longer disease duration. So the second aim of the study was to examine the concordance rate between the 2 approaches. So we were interested in seeing whether classification of group membership changed depending on the approach used. And what we found was a moderate agreement in classification between the 2 approaches using case statistics. And however, what we found was that cluster analysis misclassified approximately 12% of the patients with clinically defined impairments as having intact cognition. And the group of misclassified patients included 32 patients that were impaired in language and memory based on the clinical criteria, and 16 patients that were generalized impaired. So these misclassified patients demonstrated more subtle circumscribed impairments across tests. So specifically those patients that were misclassified who had verbal memory language impairments tended to show more subtract impairments in immediate and delayed memory rather than naming or fluency, as we see here. And those patients that were misclassified as having generalized impairments had more impairments in executive functioning, which Reyes B, with more subtle deficits in other domains. So in summary, study 2, we validate findings from smaller single-site studies in a large multi-center sample. We also show that phenotypes are robust to the methods employed. However, we find that cluster analysis misclassified 12% of the patients, which has implication for research investigations aiming to translate the phenotype work into clinical practice. So the limitations in study 2 were addressed in study 3. Specifically, the misclassification of cluster analysis is important to address given that the false negatives can prevent the identification of patients that are increased risk for cognitive progression or postoperative decline and who may benefit from patient-tailored interventions. Further, I was interested in addressing some of the pitfalls of cluster analysis, which is one of the most commonly used clustering method. First, I was interested in seeing, given that cluster analysis does not handle missing data. Second, it does not provide the probability of group membership. And then lastly, it does not compare multiple groups at the same time. So finding from study 2 raised the question on whether a more robust person-centered data-driven approach can improve phenotyping. So we examined this question in study 3, which would be submitted to Brain Communications. And for this study, we had the largest sample to date of patients with temporal lobe epilepsy in a phenotype study. So first, the aim was to utilize latent profile analysis, or LPA, to test several models of cognitive phenotypes in a large multi-center sample of patients with temporal lobe epilepsy and evaluate their demographic and clinical profiles. Second, we were interested in examining the added value of replacing missing data and how it impacts classification and model selection. And then lastly, one of the overarching goals of this study was to demonstrate the utility of LPA to inform investigations of cognitive phenotypes across other neurological disorders. So LPA is a person-centered statistical technique that classifies individuals into groups based on the pattern of responses to a set of observed variables. So in our case, the neuropsychological measures. So the primary goal of LPA is to maximize both the homogeneity within a group as well as the heterogeneity between groups. And then the optimal number of groups or classes is based on probabilities and objective and rigorous fit indices. LPA also examines the probability of membership to each cluster or class. So the available sample across 7 epilepsy centers was 1,425 patients. However, we only included 1,178 patients who had at least 6 out of the 8 tests available to minimize the number of missing data points per patient. And then given that it was a multi-site study, we only limited to those tests that were available across sites, which again included tests of memory, language, processing speed, executive function, and motor dexterity, which were the same tests included in study 2. So as I mentioned, we were interested in examining the impact of replacing missing data on classification model selection. And although we excluded patients that were missing a significant amount of data, 24% of the patients were missing 1 test, and 4% of the patients were missing 2 tests. So to impute the data, we ran multiple imputations using SPSS, and then replaced the missing scores with the average scores across the 5 data sets, and then we subjected the pool data set to LPA. So first, I want to describe some of the most relevant fit indices provided by LPA before describing the results. So first, we have the Low-Mendel-Rubin Adjusted Likelihood Ratio Test, or LMRT. It provides an indication of statistically significant improvement by comparing the solution being evaluated with a more complex solution. So a significant LMRT indicates that a more complex solution provides a better fit relative to a less complex model. And then the BLRT is very similar. It just does it through repeated sampling methods. So it compares a more complex solution to a less complex solution. Then we have the AIC, BIC, and adjusted BIC, which are based on the log likelihood function for each individual model, and lower values indicates better relatively fit. Next, we have entropy, which is a measure of how well the classes can be distinguished and is calculated from the posterior probability. So in LPA, each individual is assigned to a posterior probability for each class, rather than being assigned to one and only one class, which is what cluster analysis does. And therefore, entropy is the aggregate of these posterior probabilities, with higher values indicating that the classes can be highly distinguishable. And then lastly, we also examine the sample sizes for each class to assure that they were reasonable and that there were no classes with low numbers of patients relative to the total sample. So as previously mentioned, we tested several models based on the literature ranging from 2 to 5 classes. And we did it both for the data set that had the missing data as well as the imputed data set. So for the raw data set, the 3-class solution was the optimal solution, given that entropy was highest, as we see here. And then when looking into the LMRT, we see that it was significant for the 3-class solution, but not significant for the 4-class solution, indicating that the 3-class solution is better fit. And then lastly, the sample size were evenly distributed across the classes. And then for the imputed data set, we see that the 4-class solution was the most optimal, given the higher entropy, and given that the LMRT was significant for the 4-class, but not significant for the 5-class. And although the subsequent analysis in this study were conducted with the raw data set to demonstrate the utility of LPA handling missing data, the results of the imputed data set demonstrate that replacing missing data does impact model selection. So we were also interested in examining the agreement between the classification with a data set that were missing data and that with imputed data set, with the question whether replacing missing data changes classification. What we found was that for the 2 and 3 class solutions, there was almost a perfect agreement using the CAP statistics. However, when we look at the 4 and 5 class solutions, there was a weak agreement between the data sets, with approximately 52% and 71% of patients being misclassified with the imputed data set. This demonstrates that missing data has a greater impact for models with 4 or more classes, and that imputing data does change classification of group membership to a greater extent for these 2 models. So as previously mentioned, a benefit of LPA is that it provides the probability of an individual belonging to a group that it was assigned. So here we have the distribution of group probability for all 4 models. And when examining the probability of group membership for each model, we found that it was the highest for the 2 and 3 class solutions. And then second, we set a probability of 80% as an indication of good probability. And what we see is that when for the 4 and 5 class solutions, there were more patients that had probability less than 80%. In fact, when we look at the ranges, there were a number of patients for these 2 models that fell below 50%. And this metric provided by LPA helped us examine group membership in a more detailed manner, providing a greater level of certainty that the most optimal solution was selected. So here we have the distribution of average scores for the 4 solutions with the raw data set. However, I will focus on the 3 class solution as this was a selected optimal solution. So here we have all the tests, and we have the t-scores on the y-axis. As I mentioned, the impairment here was defined as a t-score below 40, so impairment is below this dashed line. And what we see is that there was a group of patients that were impaired across most tests, so 7 out of the 8 tests. A second group of patients that have predominant impairments in language, and then a third group of patients that were minimally impaired. So these profiles are very similar to what has been reported in previous studies, including the phenotypes described in study 2. So lastly, we use an advanced statistical approach to examine differences in clinical and demographic characteristics across the 3 classes. This approach simultaneously estimates the best fitting solution while evaluating the association between class membership and the variable of interest, so in this case, demographic and clinical variables, thus accounting for potential misclassification in class membership. What we found is that there were differences in age, education, age of onset, duration of epilepsy, and the number of anti-seizure medication, as well as the presence of MTS. Specifically, patients with no impairment were older in age, had greater years of education, had an older age of seizure onset relative to the other 2 groups. We also see that patients with multi-domain or generalized impairment had longer disease duration compared to the other 2 groups, and that patients with language impairment and those with multi-domain impairment were taking more anti-seizure medications relative to the non-impaired group. And then lastly, the patients with no impairment had less patients with MTS. So in summary, we first demonstrated that the 3 phenotype model was the most meaningful based on several fit indices in the pattern of impairment. It was the most robust to missing data, and the demographic and clinical profiles were consistent with prior literature. Second, we showed the importance of examining factors associated with missing data and determining whether different phenotypes models are robust to missingness. In this case, missing data impacted models that had 4 or more classes. We also show that replacing missing data impacted patient classification to a greater degree for models that have 4 or more classes. And lastly, we provide methods to examining the stability of these phenotypes, including examining the probability of group membership, which is provided by LPA. So as I mentioned, one of the aims of the study was to actually examine health-related risk factors and protective factors. However, due to issues with acquisition of data, I included these in preliminary analysis, which will be included in a future study. So a clinical research of mine is to use the phenotype approach to studying other factors beyond the epilepsy that may be contributing to cognitive impairment. So specifically, the phenotype approach places cognitive dysfunction at the forefront of investigation, which allows research to look at other factors beyond the epilepsy that may be contributing to cognitive profiles. And for the dissertation specifically, I was interested in looking at vascular risk factors and how they intersect with epilepsy-related factors as well as neuroimaging correlates. And my interest in investigating health-related risk factors stems from a rich literature demonstrating that vascular, metabolic, inflammatory biomarkers are associated with accelerated aging and dementia. Furthermore, this literature has identified modifier risk factors such as hypertension, obesity, physical inactivity, and diabetes that can inform intervention that patients living with epilepsy can benefit from. And then despite patients with epilepsy presenting with an accumulation of vascular risk factors as well as poor health behaviors, this has been an understudied area in epilepsy. Importantly, the phenotype approach can provide a mechanism to examining these comorbidities as well as protective factors associated with cognitive risk. So rather than examining these factors at the syndrome level, so for example, all patients with TLE in one group, which can obscure the mediating effects, investigating these factors at the phenotype level can provide patient-centered information on risk. So for example, a patient presenting with generalized impairment can present with elevated vascular and metabolic risk factors. They may have lower education, mood disorders, or taking more anti-seizure medications, which are all factors associated with worse cognitive functioning. On the other hand, patients with intact cognition may present with higher education, higher brain reserve, increased physical activity, bilingualism, or other coping mechanisms that have been shown to be a protective factor against neurological conditions. So as I mentioned, examining these health-related risk factors and protective factors on cognition across the phenotypes was an aim of the dissertation. However, due to issues with data collection acquisition, I conducted these analysis on a subset of the sample. So the sample available with the data of interest range from 16 to 33. And in the preliminary analysis, I first examined structural brain changes across the phenotypes. I also examined the impact of vascular risk factors on cognition across the phenotypes. And then I was also interested in looking into bilingualism and the presence of mood symptoms. So first, looking into the neuroimaging data, we found that patients with no impairment, so here we have the distribution of intracranial volume. Patients with no impairment had, on average, had higher intracranial volumes relative to the generalized impaired group and those patients with language impairment. And this has been shown to be a proxy for brain reserve. So these preliminary findings suggest that those patients with no impairments are demonstrating potentially higher brain reserve as measured by higher intracranial volumes. And then we compare cortical thickness between healthy controls and the patient groups. And what we found was that all three phenotypes had thinner cortex compared to healthy controls that were pretty widespread and bilateral in nature. However, we did not see a unique pattern in cortical thickness across the phenotypes. However, when we did look into the subcortical volumes, so we looked into the volume of the hippocampus, amygdala, putamen, caudate, thalamus, and pallidum, what we did find was that there was a trend for those patients with multi-domain or generalized impairment in showing greater subcortical atrophy. Then when looking into the contribution of vascular risk factors, including hypertension, hyperlipidemia, diabetes, and obesity, in addition to the clinical and demographic characteristics, we found the hyperlipidemia was significantly contributing to cognitive performance across the three phenotypes. However, the relationship was slightly different. Then regarding depression and anxiety, we found that patients with generalized impairments had more moderate to severe symptoms of depression relative to the other two groups. However, this relationship was not seen with anxiety symptoms. And then regarding bilingualism, there is a well-documented disadvantage in language measured among bilinguals where they present with lower language scores in both languages. So I had an interest in examining whether this language disadvantage was present across the phenotypes. And what I found was that it was present for those patients that had language impairments, as well as the non-impaired group. This was present for naming for those two groups and only in fluency for the language impaired group. This bilingual disadvantage was not statistically significant in the multi-domain group. However, it is important to note that the language impaired group had this bilingual disadvantage in both naming and fluency, and therefore a more extensive examination on the relationship between bilingualism and membership of phenotype is warranted. So in summary, these preliminary analyses show greater depressive symptoms in patients with multi-domain impairment, a differential contribution of demographic, clinical, and vascular risk factors to cognitive performance across the phenotypes, with the presence of hyperlipidemia being associated with worse cognitive performance. We show an expected language disadvantage in bilingual patients in the language and non-impaired group that was not present in the multi-domain group. Then we see that there's widespread cortical thinning across all phenotypes, but a pattern of greater subcortical atrophy in the multi-domain group. And then there was a trend towards higher intracranial volumes in patients with no impairment, which is thought to be a proxy for higher brain reserve. So the plan is to replicate these findings with a larger sample from study 3 and hopefully submitting this to a publication. So what do we learn about this staple dissertation? First, that cognitive phenotypes in epilepsy are stable across studies and methods employed. We provided detailed information of the most robust and rigorous methods of phenotyping, thus informing future study in this area. We demonstrate that cognitive phenotypes in TLE have unique imaging signatures that better explain the cognitive dysfunction observed within patient subtypes. And then we show the utility of the phenotyping approach in studying the impact of health-related and protective factors on cognition. So some key implications for future research in this area. First, a series of papers demonstrated that the well-documented disease burden and anatomical correlates associated with epilepsy better map onto the cognitive dysfunction observed within each phenotype, which can otherwise be obscure if all patients are aggregated into one group, just based on the epilepsy syndrome. Then we show that the clustering method impacts the phenotypes identified, and that latent profile analysis is a more robust and rigorous clustering method and should be considered in future investigation of phenotyping. Third, via the cognitive phenotype literature, we have identified an unexpected but sizable group of patients with refractory TLE that are demonstrating intact cognitive profiles, which begs the question whether there are individuals with epilepsy that present with increased resilience to epilepsy-related pathology. Further studies focusing on patients with intact cognitive profiles can inform the development of interventions aimed at mitigating the impact of epilepsy on cognition. Fourth, the cognitive phenotype approach can provide an innovative method to investigating other comorbidities in epilepsy in a patient-centered manner. And then lastly, the phenotyping approach can inform international collaboration, such as the International Classification of Cognitive Disorders in Epilepsy, or IC code, which can help replicate these findings in more diverse populations. And this dissertation has resulted in several collaborations and opportunities to present findings from these studies at national and international conferences. And I'm actually very excited that we published a review led by Dr. Herman in Nature. So part of my dissertation is published in Nature, which I think it's a pretty sweet opportunity.